Hi there, thanks to take your time to watch this video. So from today, we're going to start a PLAB or UKMLA preparation series. I hope that with this video series, you will take your preparation a little bit further with a little bit of clarity. I have done this examination for myself and I would say this exam is completely doable. Having said that, this is very tricky exam and please do not take it for granted. But if you make your foundation very clear, if you make your concept very clear, then you'll obviously get through this exam. And I want to make sure that you get most out of this video series, as this video series would be a constellation of very high-level information from the different resources. So to begin with, we'll be starting with a psychiatry series. And for today, let's talk about depression. And this video is a punchy short video regarding a depression. So without further ado, let's jump into the topic. So you should be able to diagnose major depressive disorder, and seeing all the symptomatology, it is quite overwhelming to remember all this symptomatology as it is, especially during the exam. So I made a mnemonics which would be helpful and make your task a lot easier. And I used to remember with escapism, the word escapism, of which the first word I and the last word M is the core symptom to diagnose a major depressive disorder, and remaining are minor symptoms. So how we diagnose a major depression? You need to have at least one core symptoms out of 2, and with that you need to have 3 minor symptoms out of 7. So what are the core symptoms? The core symptoms are loss of interest or pleasure in most activities. The second core symptom is constant low mood. The first symptom is loss of interest. The second symptom is constant low mood. These 2 are the core symptoms, and you need to have 1 out of these 2. The minor symptoms are fatigue, suicidal thoughts, decreased concentration, appetite change or weight loss, psychomotor agitation, sleep disturbances, and worthlessness. So you need to have 3 symptoms at least, along with 1 core symptom. So what are all these words in escapism stand for, so that we can easily remember during our exam? So I goes for interest, that is loss of interest. The last word EM, that is also core symptom, goes for mood depressing, that is constant low mood. So these 2, the first and the last word, are the core symptom. The remaining word E goes for energy decrease, that is fatigue. S is for suicidal thought. C is for concentration decreased. A is for appetite change. P is for psychomotor agitation. I is for insomnia, that is equivalent to sleep disturbances. And S is for silly or sordid thought, which is equivalent to worthlessness. So the very important point to remember here is the symptoms should have been present persistently for at least 2 weeks. So these symptoms, that is 1 core symptoms with at least 3 minor symptoms persistently for at least of 2 weeks, then you diagnose that patient as a major depressive disorder. And please, you cannot miss this. The questions are very straightforward in the examination. Just remember this symptomatology, and if you find my mnemonics helpful, you can remember with this mnemonics, or you can make it your own. Please, the take-home message from this slide or this presentation is escapism. Please just remember escapism for at least 2 weeks persistently. So next, we are going to talk about reasons for hospital admission. So why we admit the patient with depression in the hospital. So there are few very important reasons which are very important for clinical practice as well. So when the patient come with a serious risk of suicide, if the patient have serious risk of self-harm or harming others, if the patient have serious risk of harming others, significant self-neglect, if you find a patient having a severe depressive or psychotic symptoms, if the patient don't have social support, if the patient is breaking down, or you want to initiate an electroconvulsive therapy for that patient, or the patient is treatment resistant so that you want to monitor that patient. If the patient is treatment resistant, and so that you want to admit the patient for the monitoring, that would be really helpful. So what are the reasons for admission? The question going to ask you in a different way. You just remember, you should be clear that when to admit the patient. If the patient have a risk of suicide, you admit the patient. If the patient have a risk of harming other, please, for the safety of others, admit the patient in the hospital. If the patient is having a self-neglect, please admit the patient. If the patient is having a severe depressive symptom or psychotic symptom, then admit the patient. If the patient is having a lack of social support, or you want to admit the patient for the initiation of electroconvulsive therapy, or the patient is treatment resistant, then you will admit the patient in the hospital. So next thing, what I want to make you clear is, for the admission of the psychiatric patient, for the examination point of view, at least what you need to remember is there are two types of admission. That is, please remember, at least voluntary admission and involuntary admission. The psychiatry patient, you'll admit either the patient voluntarily or involuntarily. So involuntary means that if the patient is unwilling or unable to make a request for the admission, a relative or a friend makes the application on behalf of the patient, then it is involuntary admission. So what is voluntary admission? If the patient is willing, if the patient comes to the hospital by himself and he can make a request by a major or a guardian of a minor for the admission to the medical officer, then it is voluntary admission. So what is voluntary admission? If the patient is capable of making decision of admission for himself, he can request admission for himself, he is willing to admit for the admission, then it is voluntary admission. So what is involuntary admission? If the patient is unwilling or the patient is unable to make a request for the admission, and for the behalf, on the behalf of the patient, a relative or a friend makes an application to the medical officer, then it is involuntary admission. So this is very important, because you'll get a question regarding all the psychiatric patient or patient having a depression and having a risk of suicide or harming others, and he's having a very severe depressive symptom along with the psychosis. Then how will you admit the patient? So it is under the compulsory admission or involuntary admission, because he's not able to make a decision because he's having a very severe psychotic symptoms. But having any psychiatric disease never means that he is not capable of making decision. So sometimes you need to assess the patient. So according to the question, you need to be very judgmental and very vigilant. So what the question is asking. So if it clearly state or indicate the patient don't have a mental capacity, or he's not able to make a decision, he's not willing to admit take admission, but he have a serious risk of suicide or harming others and all that, then you need to admit that patient under involuntary admission or a compulsory admission. So please be vigilant with the question in the psychiatry admission, at least. So in the next slide, we are going to talk about a risk factor of the suicide, because the risk factor of the suicide is very important. That's why we are admitting that patient. So what are the risk factor of the suicide? If the patient have a previous suicide attempts, if the patient have previous self-harm, if the patient is recent divorcee, or patient recently have undergone a divorce, if the patient is bearing with the divorce or recently undergone the divorce, or the patient is divorcee, then his or she is at risk of suicide. If the patient abuses alcohol and drugs, if the patient have a depression with other mental illness, then he is at a little bit higher risk of suicide. And the last one is low socioeconomic status. So what are the risk factors for the suicide? Suicidal attempts, self-harm, divorce, alcohol and drug abuse, depression with other mental illness, and socioeconomic status. So what are the risk factors that you should or you need to remember? If you can, all of it. If you cannot, please just read this question. The person with all these risk factor, which each or are the biggest risk factor? So if you can answer, the first one is previous suicide attempts. Second most biggest risk factor is previous self-harm. And the third one is divorce. So please, if you cannot remember all, at least remember previous suicide attempts, previous self-harm, divorce, then the patient is having a higher risk of suicide. So for the further information, the male gender has a higher risk of completed suicide, whereas the female gender has a higher risk of suicide attempts and deliberate self-harm. So it is very important. Just remember the 3 risk factors for the suicide. If you can, please remember all the risk factors for the suicide. Why? Because if you find any of these risk factors, then the patient is higher risk of suicide, so that you need to admit the patient in the hospital. So let's jump into the management of the depression. So how do we manage the patient with the depression? So the first treatment, the first management of the patient with the depression is cognitive behavioral therapy, CBT. So it is the preferred management over any other drug or any other antidepressant for the treatment of the depression. So always offer CBT before the antidepressant. So for the newly diagnosed patient with depression, should have cognitive behavioral therapy as a preferred management over the antidepressant. So, but in the clinical practice, what we do is, the referral to see the psychologist, who can perform the CBT are long. It will take a month, so that the main GP will start an antidepressant while waiting for the patient to see the psychologist for the cognitive behavioral therapy. So in the clinical practice, practically what most GP do is they put the patient on the antidepressant. They already start the antidepressant, so that they start the treatment while awaiting for the psychologist to perform CBT or do the needful. So nice guideline recommendation. For the mild to moderate depression, you always do low intensity psychological intervention, that is CBT. For the mild to moderate depression, low intensity psychological intervention CBT and the routine use of antidepressant should be avoided whenever possible. But for the moderate to severe case of depression, you start on antidepressant with high intensity cognitive behavioral therapy or high intensity psychological intervention, that is 1-to-1 cognitive behavioral therapy. So nice guideline. The mild to moderate depression, low intensity psychological intervention, that is group CBT, and whenever possible, please avoid the antidepressant routine use. For the moderate to severe depression, use the antidepressant, and high intensity psychological intervention is warranted, and that is 1-to-1 cognitive behavioral therapy. So when we have to start the patient on antidepressant, how we do is we start with selective serotonin reuptake inhibitors. That is, we start with SSRIs. And if the patient is not responding in 2 to 4 weeks of time, we assess the patient in 2 to 4 weeks of time, and we check for adherence to the medication. So always check the patient adherence to the medication. If the patient is not adherent to the medication, please counsel the patient for the importance of compliance and advise that it will take up to the 6 weeks for the full effect, because a lot of patients will drop their medication not seeing the result after the use. So when you start the medication, counsel the patient that please adhere to this medication. This will take at least 6 weeks to take the full effect. So you assess the patient in 2 to 4 weeks, you check the adherence, and you'll see that if the patient is not adhere, you'll counsel the patient. But if the patient is adhere to the medication, the adherence to the medication is good, what you will do is you continue that medication for next 4 weeks. So you assess the patient in 2 weeks, you see the patient is adhering, and you continue that medication for next 4 weeks to see the response. Despite you did not get the response in 2 weeks, you want to see the effect of medication in the next 4 weeks. So you'll get either of the response. If the patient is adherent and responding in the 4-week time period, then you want to continue that medication. So when the patient recovers, you also want to continue for at least of 6 months. This is very important. You want to continue the medication after the recovery at least for the 6 months after the recovery, because you want to reduce the risk of relapse. So if the patient is adhered to the medication, and after the 4 weeks, if you see the patient is responding to the medication, so you want to continue the medication. And if the patient is recovered, please continue the medication for at least 6 months after the recovery to reduce the risk of relapse. But if the patient is adherent to the medication, but you still have no response after the 4 weeks of use, so adhere but not responding after the 4 weeks of use, what you will do is you titrate and try to increase the dose of SSRI. So what you will do if the patient is not responding in 6-week time period, then you titrate and increase the dose of SSRI. If that is also not responding, then you want to shift to the different SSRI. So you shifted to the different SSRI, still no response, then you want to shift to the different class of antidepressant. It is a different class of antidepressant. So what NICE guidelines suggest for the different class of antidepressant, it is either mirtazapine or venlafaxine to start with. And if you still not get a response, if the medication continues to be ineffective, then what we will do is we keep switching until the patient find one that works. So what we'll do? First of all, we'll check the adherence. If the patient is adhered to the medication, we continue for the next 4 weeks to see the response. If the patient is responding, continue that medication. When the patient recovers fully, you still want to continue for the next 6 months after the recovery to reduce the relapse. But if the patient is taking the medication correctly, adhere to the medication, but not responding in the next, in the 4-week time period, then we want to increase the dose of SSRI after the titration. If not responding, switch to the different SSRI. If still not responding, switch to the different class of antidepressant, preferably mirtazapine or venlafaxine according to the NICE. And if you are still not getting a response, if the medication continues to be ineffective, then keep switching the medication until you find the medication for the patient that works. For example, you want to switch to the amitriptyline or trazodone and etc. and etc. So this is basically the overview of the management of the depression. So how we do a hospital management of the depression? So for the general steps to involve in the hospital management of the depression is first admit the patient. That could be either voluntary admission or compulsory or involuntary admission. As per the patient, it is individualized, and it depends on the patient symptomatology and the presentation. And after you admit the patient, you send the investigation to rule out all the secondary causes, for that symptoms and likely symptoms. And next, you want to treat with the medication like we have mentioned, like SSRI. But when you admit the patient, it is likely that the patient is having a severe kind of depression or having other risk factor, other reasons for the admission. So we consider, serotonin and norepinephrine reuptake inhibitors, SSRI and SNRIs. And if that also does not work, then we consider augmentation with lithium, with the cognitive behavioral therapy. The lithium is, mood stabilizer, and combined with cognitive behavioral therapy, patient might respond. Most of the patient might respond. And if nothing works, the last resort is always electroconvulsive therapy. When we admit the patient, if nothing works, the last resort is electroconvulsive therapy. So this is the general overview of the management of the depression in the hospital. So first you admit the patient, you send the investigation to rule out all the secondary causes, for that particular symptomatology and the presentation. And next, you want to treat with medication such as SSRI. If that doesn't work, you consider SSRI and SNRIs. If that also doesn't work, you want to augment with lithium with CBT. If nothing works, the last resort is ECT. So let's recall why we admit the patient in the hospital. If the patient is having a depression, the reason for the hospital admission are risk of suicide, harming other, self-neglect, severe depression with psychosis, lack of social support. You want to initiate that patient in ECT, or the patient is having a treatment resistant and you want to observe, then you will be admitting that patient in the hospital. So let's dive into the topic of high-yield antidepressant medication. So the first one is, of course, SSRI, that is selective serotonin reuptake inhibitors. The example of SSRIs are citalopram or escitalopram, fluoxetine, paroxetine, and sertraline. So what are the high-yield information? The full effect of SSRI may take up to 6 weeks. So you want to assess in 2 to 4 weeks and check the adherence. And if the patient is taking the medication correctly, then you want to continue for next 4 weeks, that is total 6 weeks, so that you will see the full effect of the medication and reassess the patient. So full effect may take up to 6 weeks. The next 6 is you continue at least 6 months even if the patient recover fully. So if the patient says I'm feeling good and I think I'm recovered, then you want to continue the medication for next 6 months despite the patient is recovered, so that you reduce the risk of relapse. It is quite high if you don't continue for next 6 months. And if you want to stop SSRI, please, this is very important. If you want to stop SSRI, the dose should be tapered over the 4 week of time period. So if you want to taper the dose, the dose should be tapered over the period of 4 weeks. So let's go into the side effect of SSRI. So what are the important side effects? The SSRI causes the GI bleed. Please remember that SSRI causes the GI bleed. So please don't use with aspirin, Plavix, warfarin, triptans, or low molecular weight heparin. So this is quite high-yield information. You will be tested in the exam. Take a note of it. So it causes GI bleed. So you don't want to use it with any drug, at any blood thinning drug, that is aspirin or Plavix or warfarin or low molecular weight heparin. So in that case, please go for mirtazapine. It is safe to use with low molecular weight heparin or warfarin or aspirin than SSRI. So SSRI, GI bleed, you don't want to use with any blood thinning medication. So please check if the question give you all the medication mentioned, and if you want to start the patient in SSRI, please do not pick, never ever pick SSRI if the patient is on, low molecular heparin or warfarin or aspirin and so on. Always choose mirtazapine. And the next side effect is it lowers the threshold for the seizure. So if the patient is on anti-epileptic drug, then please do not use SSRI. Instead, you want to use, you want to use sertraline if there is no option, beyond SSRI, or if you have to choose SSRI, then you want to choose sertraline. That is the preferred option. And the third side effect is hyponatremia. It is good practice to, always monitor for electrolyte and urea, and, because it causes the hyponatremia. So always check the electrolyte. And the last side effect is sexual dysfunction, that is common in both male and female. And the next drug is sertraline. Sertraline, why this is important is because it is the best medication to pick. Sertraline is the best medication to pick if you have any comorbidities. So what are the comorbidities? If the patient have myocardial infarction, choose sertraline. If sertraline is not there in the patient with MI, please pick citalopram or escitalopram. So if the patient with depression come with, have a history of MI, recent MI, then pick sertraline. If not there, pick citalopram. And the next comorbidities is if the patient is breastfeeding, you want to choose sertraline as a preferred medication. And if the patient is on antiepileptic medication, you want to choose sertraline during the exam. So basically, if you don't remember anything, please just remember MI. You always go for sertraline. If not there, you choose citalopram. So next, we'll be talking about fluoxetine. So the fluoxetine, you just need to remember one thing, that is if the patient is below 18 years of age, then it is the best medication to pick if the patient is having a depressive symptom. So you want to start the patient on the antidepressant and the patient is under the 18 years of age, then choose fluoxetine. It is the only antidepressant licensed for this use. The last one, it is the added information. I want to mention it here and you'll find it somewhere else also because it is related. So what is serotonin syndrome? Serotonin syndrome is SSRI toxicity, because SSRI means selective serotonin reuptake inhibitors, and if you use it or abuse that medication, then you will face the serotonin syndrome. And if the patient is having a SSRI toxicity or excess intake of SSRI, then it is characterized by fever, sweating, tachycardia, agitation, muscle rigidity, twitching, neck stiffness, etc. Then please suspect the patient is having a serotonin syndrome. So next antidepressant we will be talking about is tricyclic antidepressant. So example of tricyclic antidepressant: amitriptyline, trazodone, docilepine, etc. So very famous drug, amitriptyline, trazodone. So what are the high-level information regarding TCA? It is the side effect of TCA. So how we are going to remember the side effect of TCA? It is 7C: cardiotoxic, coma, convulsion, constipation, you cannot pee, that is the urinary retention, congestive glaucoma, and cracked lip due to the dry mouth. So what are the 7C? Cardiotoxic, coma, convulsion, constipation and urinary retention, that is cannot pee, congestive glaucoma, and cracked lips. So what are the contraindications? So you just remember side effect. Cardiotoxic, so in the ischemic heart disease, you don't want to use it. In the patient with glaucoma, diagnosed glaucoma, you don't want to use this medication. So at least remember these two: ischemic heart disease and glaucoma, you don't want to use tricyclic antidepressant. And all the antidepressant actually lowers the threshold for the seizure. So if the patient is on antiepileptic drug, please, you also don't want to use tricyclic antidepressant. So the next is, there are other high information regarding a tricyclic antidepressant, and that is if the patient is post-stroke depression. If you diagnose the patient having a post-stroke depression, then the drug of choice is nortriptyline, that is also a TCA. And next thing is, if the patient is having a depression with OCD, then you want to use clomipramine, that is also a TCA. So nortriptyline and clomipramine: nortriptyline for post-stroke depression, clomipramine that is for depression with OCD. And other thing I want to tell is regarding the mirtazapine and venlafaxine. You remember when we have mentioned mirtazapine and venlafaxine? So, yes, in the management of the depression. So if you want to switch on different class of antidepressant, then mirtazapine and venlafaxine are the preferred drug by the NICE guideline. So you want to if you want to switch on different antidepressant, the first choice is either mirtazapine or you start with the venlafaxine. So mirtazapine causes the drowsiness, so that if the patient is having a difficulty sleeping or having insomnia, then it might be helpful for the patient with insomnia with depression. And venlafaxine, So regarding the venlafaxine, it is more effective if the patient is anxious. So if the patient is anxious, use venlafaxine. If the patient is having insomnia and difficulty sleeping, use mirtazapine. And while using the venlafaxine, please do the baseline blood pressure and ECG. That would be very helpful to monitor the cardiovascular side effect of venlafaxine. So let's talk about high-yield but a miscellaneous topic regarding associated with a depression. The first is psychotic depression. So what is psychotic depression? So it is a subtype of major depression that occurs when severe depressive illness includes some form of the psychosis. So what is psychotic depression? Name itself telling you the answer. It includes the severe depression with some form of psychosis. Psychosis might be hallucination, delusion, or some other break with the reality. So please remember that if the patient is having a severe depressive symptom with some form of psychosis, that is either hallucination, delusion, or some other break with the reality, then you diagnose that patient as a psychotic depression. It is very important. You will be tested in the exam. And the next is seasonal affective disorder. Seasonal affective disorder. It is a type of depression that comes and goes in a seasonal pattern. So it is sometimes known as winter depression because the symptoms are more apparent and profound and tend to be more severe during the winter. So that's why it has a seasonality, and so the name goes seasonal affective disorder. So let's talk about electroconvulsive therapy. The NICE guideline recommends that ECT is used only to get a rapid, if short-term, improvement of severe symptoms after an adequate trial of other treatment has proven ineffective, that is treatment resistant, and or when the condition is considered potentially life-threatening in an individual with severe depression, catatonia, and a prolonged severe maniac episode. So if the patient is having a maniac episode or prolonged depression, catatonia, or severe depression, and the patient is at potentially life-threatening risk factor, and all the treatment are proven to be ineffective, then you use ECT. So basically for the depression, the ECT is a last resort. So for any other depressive illness, it is also the last resort if the treatment fails and if the patient is having a life-threatening, potentially life-threatening condition. So when the ECT ends, you might want to put that patient on the antidepressant, and this will prevent the recurrence rate. And how will we do ECT is there is a typical course length. We'll do at least 6 sessions and at least 2 sessions per week. That is, we go for 3 weeks and every week we'll do 2 sessions, total of 6 sessions. So knowing the etiology of depression is not so important for exam, but for your knowledge, there are different factors for the development of depression. That is biological factor, psychological factor, and social factor. So there are other the reasons or causes for the depression. So we don't want to go into the details because it might confuse you and overwhelm you with a lot of information. So I just want to skip this information, and this is I would say important. If you want to if you can remember it, it is very good because it is according to the ICD-10 and it is for a depressive episode. And if you can classify mild depressive episode, moderate, and severe depressive episode, if you can, then it is well and good. If you cannot, please just don't bother. You have to remember the major depressive disorder. So let's do a practice session with a few questions, how you will get the questions in your exam. So what are the few important points you want to figure out in this question is, he recently suffered from MI. He's on aspirin and he's having insomnia, weight loss, don't feel like doing anything, stop socializing, gets tired easily. So it is a straightforward case of depression, but with MI. So what is the best drug to choose? It is, of course, citalopram. So if the citalopram is not there, then you might want to use sertraline, of course. So this ends our session. If you want to do a further practice of the examination questions and all the information that you have gathered, please do practice in our website. We have created a course for a PLAB 1 where you can go and practice with our interactive sessions. What I mean by that is you can just reinforce all the knowledge you have gathered and studied from the video and all the notes in the course itself, and you'll not get the interactive practice session right away. You'll get that interactive practice session after the few days of the topic you have studied. Like, for example, if you have studied a depression today, you will get the interactive session and the practice questions after 2 or 3 days or so, and again in the 1 week, so that it will reinforce the information you have gathered. So thank you very much for watching this video. I hope you find this video helpful.